I am Bernard Dan, Editor-in-Chief of Developmental Medicine and Child Neurology. Today I'm discussing a paper with the first author, Dr. Rohlwink, and the title is Clinical Characteristics and Neurodevelopmental Outcomes of Children with Tuberculous Meningitis and Hydrocephalus, and it's published in the May issue. Ursula, hello.
Hello, it's such a pleasure. Thank you, Bernard, for the opportunity to discuss this paper. This manuscript deals with the clinical laboratory characteristics of a cohort of pediatric patients who were admitted to the Red Cross War Memorial Children's Hospital, where I work as a neuroscientist in the neurosurgery unit. And the manuscript covers various aspects of this cohort, which were enrolled as part of a prospective study looking at biomarkers of brain tissue injury and inflammation in children with TB meningitis. And the paper summarizes the clinical findings of the children, their laboratory findings in terms of CSF, chemistry, hematology, and diagnostic tests, provides some brief information about their radiological outcome, and then some more extensive information about their clinical outcome as determined by clinical assessment at 6 months. And then neurodevelopmental assessments were also conducted on these patients using the Griffith's mental scales test, also at 6 months. And the data demonstrate that despite the fact that this was a patient cohort with hydrocephalus who represent more severe spectrum of disease, more than half of our patients actually made a good clinical outcome, which is very positive. And it's a demonstration of how effective and prompt medical diagnosis and treatment can actually lead to good outcomes in these patients, although TB meningitis is such a lethal form of extrapulmonary TB. And I think particularly because this was a hydrocephalus cohort, there was a lot of attention and a lot of effort paid to trying to manage their hydrocephalus and their raised intracranial pressure as best as possible. And one can see, I think, also the role that effective medical management has if we look at the GCS and the severity scoring of the TB meningitis at admission versus after 1 week, where we see that their clinical staging actually improved in about more than 47% of the patients. And I think that was a very positive outcome. Having said that, of course, we did have a mortality of 16%, which is a little bit higher than what we see in TB meningitis cohort overall, those with hydrocephalus and those without. Mm-hmm. But what we did see was that those patients who died often deteriorated quite dramatically within the first 10 days of admission. And I think that's also an indication, again, of the importance of trying to capture this disease as early as possible and to institute good treatment as promptly as possible to improve their outcomes.
This is clearly a very important factor. Which were the other factors? I was surprised to see relatively small a proportion of children with HIV co-infection. Did that come as a surprise to you?
To be honest, actually, Bernard, there's been quite an effective mother-to-child transmission program that's been rolled out in South Africa for the last decade. And I think that, the low HIV co-infection rate is really a testament to how well that program is working. So it wasn't an entire surprise that we had such a low HIV co-infection rate, because in general at our hospital, we really have noticed that the HIV rate of that we see in kids is quite low. So it's quite a different case, of course, in our adult patients in South Africa.
Mm-hmm. And inflammation, is that a major factor to take account of?
Yes, inflammation is enormously important to TB meningitis in general because of the development of the very prolific exudate that collects in the base of the brain, and it has a lot of negative consequences. It blocks the flow of the cerebrospinal fluid, and that's when we see the hydrocephalus and the raised pressure. And of course, raised intracranial pressure compromises cerebral blood flow and puts patients at risk of ischemia. But then these patients have the added risk of ischemia due to the vasculitis, which results from the inflammatory exudate coating the major vessels and the circle of Willis. So they have a very high risk of ischemic damage, and I think that's really why we see so many infarcts in these patients. So inflammation is certainly very important. In the case of HIV co-infected patients where we see immune reconstitution syndrome, that is something which is seen quite dramatically in adult patients, and there have been a number of studies that have also come out of South Africa that have really investigated that in terms of how best to manage these patients, when to start their antiretrovirals relative to their TB treatment and so on. It's a complex area, yes, absolutely, very important, but not something that we see very commonly in children in our context.
Right, and now more directly on the neurodevelopmental outcome, how do you think we should best assess neurodevelopmental outcome in this sort of situation?
It's a challenging question. It's a challenging task for a number of reasons, really. I think that looking at neurodevelopmental outcome is very important because, as the manuscript reports, although 21 of the 44 patients had a good clinical outcome, the overwhelming majority of patients who had their Griffiths test done had deficits, whether they were motor or in the various other scales, eye-hand coordination, performance, reasoning, language, personal social issues. And I think that really highlights to us that as much as they're looking clinically well, they've got a lot of challenges and they need extra help, and that the disease is not only affecting them on a gross functional level, but also on a much finer functional level. And I think that's important to their futures, especially when you see this disease in areas where resources are limited and additional rehabilitative and schooling support is lacking. How best to measure it is challenging because of those same reasons. Because resources are limited, it's difficult to find the staffing resources to actually do a lot of these developmental tests. They take quite a long time. They need somebody who's appropriately trained. And in our case, we had 3 different language groups. So we had English, Afrikaans, and Xhosa-speaking children. So it's important to take into consideration appropriate translation and cultural sensitivity. And I think that's where we struggle in terms of developing or validating a universal test for neurodevelopment, because there's so many cultural and language factors that play a really important role in how a test needs to be administered, how the test needs to be structured, and how the test needs to be evaluated. In terms of the Griffiths, it has been validated in the South African context in our 3 different language groups, but it has not been normalized in our context. So studies that have used it have generally scored their patients according to the norms that are provided with the test, which are, of course have been developed in a first world setting. And that's why we try to include a control group, an appropriate control group in this study. So we selected children who came from similar socioeconomic status backgrounds, from a similar residential area, language group, and race group, so that we could assess whether at baseline these children are actually performing at the same level as the children for whom the norms were established for the Griffiths. And what we found was that our control group performed poorly in comparison to the standard norms in more than 3 of the subscales. And that was an indication for us that at baseline, our cohort of children that would present to our hospital, which is a state institution, their baseline functioning is lower. And therefore, we compared the outcomes of our TB meningitis cases to a control group of their peers to give it a more accurate reflection of the degree to which the disease has actually affected their outcome, while taking into consideration the various contextual factors that influence development in children. So it's difficult. There are few tests that have been developed taking into account the fact that there are so many cultural differences in different countries across the globe, and I think perhaps we never will quite get there. But I think it's important in individual countries to think about those factors when selecting a test, when administering a test, and when working out how best to score a test.
Right. I would like to ask you about secondary prevention, how we could diminish the proportion of disability in those children. And then I will ask a final question about primary prevention. And based on your experience, where do you think we should be heading, and where should we place the emphasis for primary prevention of tuberculous meningitis? But first, perhaps, how can we decrease the burden of disability?
That's a really important question, Bernard, and I think it's a difficult one to answer. Because the disease is so non-specific in its presentation, these patients often present quite late when a lot of damage has already been done and it's difficult to reverse that. But I do believe very strongly that there is still always a window of opportunity to make a difference. And I think that comes how raised pressure and ischemia are managed. I think at the moment, treatment for TB meningitis is largely the same as treatment for pulmonary TB. It's the course of anti-TB drugs, and then in the case of TB meningitis, the addition of steroids. But perhaps that's not actually appropriate. The lung is a very different organ from the brain, and the vulnerabilities of the brain, especially a brain that is exposed to ischemia, are really quite a different matter. And I think that we haven't grappled with that sufficiently, how best to treat the brain that's infected with TB rather than to treat tuberculosis in general. So I think, there are various studies that are looking at higher doses of some of the TB drugs, that are looking at different combinations of the drugs, and it will be interesting to see what the outcomes are of those. But we need secondary injury monitoring and management. So, for example, what we did as part of the study as well, and we will publish the data in the coming year, was we also looked at measuring their pressure and their brain oxygenation. We did that invasively and also non-invasively. So invasively we used an indwelling brain oxygenation catheter, and non-invasively we used near-infrared spectroscopy. And what it shows us is that these kids are really, at baseline, are very ischemic. And even small increases in their pressure within a supposedly normal range can severely compromise their brain oxygenation further. So I think we need to look more at diagnosing ischemia and treating it. It can be as simple as just providing nasal prong oxygen. We've seen that can have a dramatic impact on brain oxygenation readings. And for more severely ill children who do land up in ICU, one can optimize their blood pressure. I think how their intracranial pressure is managed is very important. There's very little consensus at the moment about how to do that. Some people will do an endoscopic third ventriculostomy immediately. Some centers will shunt immediately. Some centers will do a lumbar puncture once a week. Some centers will do a lumbar puncture every day. So I think more research really does need to go into looking at how we can provide secondary injury monitoring and management strategies that are tailored to these children with a very severe disease in the brain.
And so the last question, how do you see the future in terms of primary prevention?
Primary prevention is very, very tricky. I think that one of the avenues that is being extensively explored is trying to develop a better vaccine. We know that BCG is important, that it seems to confer some protection against the more severe forms of TB, but certainly it is not adequate. There are a lot of projects and a lot of resources that are going into trying to develop a better vaccine, and I think that would be a major step in the right direction if our colleagues are able to find that. Other aspects that are important in terms of primary prevention are health education around TB. There's a lot of stigma associated with TB still, and I think there's a lot of energy also going into informing communities that they should present to hospital if they suspect that they've got symptoms, because it is a disease that's airborne and spreads through crowds. The quicker people present and go on treatment, the better for their surrounding communities. Similarly, there's a lot of health education about completing treatment so that we can try to stem the rising incidence of drug-resistant forms of TB. I think that's really important because that's a whole other challenge that we're going to face and that we are facing at the moment. And then, a lot of it is also about a lack of access to adequate healthcare systems, and that's why patients are presenting late. So it is a complex issue that involves, I think, education, health systems, social systems, community involvement, It's complex, but I think, a lot of countries that face this disease, and I can speak really from my own country, that here in South Africa there's a lot of effort going into trying to stem the tide of this disease. But it's difficult, and TB is the oldest bacillus, it's the oldest bug that we have, and it's still thwarting us, as much as people are trying to understand how to best kill it. It evolves incredibly rapidly, and it's incredibly intelligent. And so it's a huge challenge for us.
And it's also important to promote awareness in a region where tuberculosis is less endemic for early recognition. Yep.
Yes, absolutely. And I suppose also now as there's increasing movement of populations, it's no longer a disease that is restricted to certain parts of the globe. Certainly not. You're 100% correct.
Good. Well, this has been a very stimulating discussion. Thank you very much, Ursula. And greetings to the rest of the team too. Thank you very much.
Well, thank you so much for the opportunity to be able to discuss this paper. Thank you also for the opportunity to be able to disseminate these findings through developmental medicine and child neurology. It's been a pleasure for us.